So my talk will take place in how to evaluate subepithelial lesion when we have to consider resection or observing such a tumors. If you allow for me, I will start with the case presentation. We have 47 all female chronic came with like 6 months history of this and as usual, we found a subepithelial lesion at the upper part of esophageal with normal overlying mucosa. So this is usually happen to us. What we have to do next if we see such a lesion? Shall we refer for the surgeon to resect? The segment is not the optimal for surgery. Should we consider endoscopic resection? Still, it's not that safely without complication. Shall we leave such a tumor and don't consider it at all? So subepithelial lesion, usually they are asymptomatic. They are found incidentally if you are doing the scope for unrelated reasons. Most of those patients came with symptoms, either they have dysphagia or iron deficiency anemia. So what we are worried about is only the minority of those cases, which is the malignant, are less than 15%. Most of the subepithelial lesions are benign, but we are all worried about the malignant potential of this. So before considering any resection, we have to consider, does the patient have a symptom? So any patient symptomatic should be considered for resection unless there is clear contraindication. What about malignant potential of these tumors? And patient aspect, the patient anxious about his diagnosis, about the complication from the follow-up, we should consider resection those tumors. So as we know, we have certain types of subepithelial lesion has definitive for malignancy like neuroendocrine tumor, high risk GIST or lymphoma. And some have malignant GIST potential like a granular cell tumor or very low GIST. So what we have tools to evaluate for the malignancy, we have of course the endoscopic plus minus biopsy, US adding another value, to predict malignancy, especially if we need tissue diagnosis. And of course we can consider endoscopic resection technique as a part of evaluation. And of course the follow-up is the last option to be considered. So what we have to assess in our endoscopy, so we look usually, those lesions are, where is the pointer? So usually we have a normal mucosa actually overlinked. So if we have a very, clear yellowish demarcation at the lesion, this indicates this lesion is lipoma. If you have a bluish, discussion, this most likely represents a vascular lesion. And if you have translucent, those lesions usually are associated with gastritis cystica provenda. And we should think about the size, the location of the lesion itself. A lesion in the greater curvature of the stomach, very large, most likely representing GIST. And if it's in the antrum with umbilication, most likely representing ectopic pancreas. And if there is any presence of ulceration, this is raise the possibility of malignancy. And we can even, check for the mobility and consistency of the lesion by using the rolling sign, which is around just by just trying to push the tumor in the border. Usually if they are mobile, if they are submucosal. If you have dealing with rolling sign is negative, this is indicate very wide base musculus proprioceptive attachment or severe fibrosis or ulceration in the lesion. And we can check even for below or the cushion sign, which is indicate the content of the lesion, most likely either liquid or lipid. We can take a biopsy. We called it bite on bite, although diagnostic is very low based on the studies, and there is a lot of limitation with too many biopsies and increased risk of bleeding. A newer technique by unroofing the lesion and using the ESD technique to direct biopsy has been shown by evidence high diagnostic value and low bleeding rate, but if it's done by expert hands. Another single incision, or what we call the zinc biopsy, has been shown by meta-analysis. It's higher diagnostic with acceptable at first event, most likely non-severe bleeding. EOS can add advantage for our evaluation. Why? Because we can stage the disease surrounding, looking for the lymph node, which is, very important in decision of the resection if you take it endoscopically or surgically. Looking for the indication for the treatment. If we have hypoechoic lesion with a high feature of malignancy, we should consider treating such a lesion, even if our biopsy came to be negative. And decision to consider the resection, because if we have a lesion originating from second layer, we can take it endoscopically. But if you have a severe, large extramural lesion, we should consider surgically, not, endoscopic resection, and of course can be used for the follow-up. So the EOS is considered the method of choice for evaluating subepithelial lesion. It serves the two important, role, which is a characterization of the lesion and the tissue sampling, and it found to be superior for cross-sectional imaging for lesion less than 2 centimeters. And as per ESG guidelines, the accuracy of originating layer was up to 75%. Especially, if we are looking for submucosal, it was above 80. The size is high accuracy. And the feature is pathognomonic if we look for lipoma and vascular lesion. But if we are dealing with hypoechoic lesion, the accuracy of EOS is dropping. So an example of we reach up to 89%. But if we consider the ectopic pancreas, this sensitivity dropped down to 50%, and this is because the heterogeneity of the originating layers usually. So this is just an example. If we consider second layer originating hypoechoic lesion, you can see a lot of differential diagnosis, and most of them, they are carrying a risk of malignancy. So in those, back to our case, we found this patient have a homogeneous hypoechoic lesion, 3 by 4 centimeter, originating from muscular subpropria. So the question, when we have to do a tissue sampling. So as per ESG guidelines, any lesion suspected for GIST should be biopsied, or lesion more than 20 millimeter in the diameter or have high risk stigmata. Also the Japanese and the Chinese, they recommend resection for all GIST suspected cases, so all those lesions should be biopsied. The National Comprehensive Cancer Network, they suggest no biopsy for less than 20 millimeter. So what we have method, FNA, FMP. FNA, as we know, it has a low cellularity, it has a lot of limitation, and it can be difficult to obtain from fibrotic or necrotic tissue. So the FMP came to come over this with higher diagnostic accuracy and lower number of pass. And we look for the data comparing the US FNA, FMP in meta-analysis. The US FMP was higher in adequacy, accuracy, and the number of needle passes. And the ESG recommend FMP or mucosal incision biopsy for any lesion more than 20 millimeter. For those less than 20 millimeter, they consider mucosal incision biopsy to be the first choice, and the USFMB can be considered the second. What if we compared it to the Python bite? It found to be higher accuracy and adequacy and low adverse event. And this is nice, neat work meta-analysis comparing 8 randomized clinical trial looking for our all, tissue requiring biopsy, and they found USFMB and mucosal incision biopsy as superior for the others. What about the rule of enhanced imaging EOS? Contrast enhanced EOS can be characterized as subepithelial lesion, and it highly specifically in GIST patient. We still have insufficient data about elastography, but all of this cannot replace the need for tissue samplings. And you can see here in contrast enhanced EOS, hyper-enhanced with the GIST compared to leiomyoma patient. Elastography, this is a nice Korean study when the author able to correlate some strain ratio and to specify the subepithelial lesion, but still those data need more validation. Artificial intelligence, it's of course, as Pradeep said, this is a future, and this is up to my knowledge, this is the only study in subepithelial lesion looking for the AI on EOS, and unfortunately AI came to be better than expert EOS opinion. So as I mentioned, some of the patients, even if you told them your lesion is a benign, they still have a tremendous emotional burden regarding the malignant potential increase in the size and the complication from the follow-up. So we have to consider resection. I will not talk about endoscopic resection technique because I think there is a dedicated lecture about it. But what I would like to mention, based on the size, based on the layer, we can consider the endoscopic resection. So EMR, either using CAB or irrigation or conventional MR can be used for smaller lesion less than 2 centimeters. So back to our case is our case biopsy showing tubular myoma, and the patient went for STAIR. So what we are doing in a STAIR, so it's like a POEM technique. So initially you have to go like up to 3 to 5 centimeters above the lesion. Then you made the incision. So why we need to go above the lesion? Because if you start at the lesion level, you will find difficulty to cross, the border of the lesion, unless you damage, the capsule. So basically you choose above 3 to 5 centimeters to be able to widen your tunnel before, reaching the lesion itself. Is there any way to make it faster? So anyhow, once we're getting inside the tunnel, we start dissecting the tumor, especially from the mucosal side initially, and avoid any mucosal injury. And once we're done, we can, resect from the muscle attachment. It's not working. Okay. So what the ECG recommend for those asymptomatic patients, they are against surveillance in leiomyoma, lipoma, or ectopic pancreas. But for those or asymptomatic lesion less than 20 millimeter, they can consider only gastroscopy, for surveillance, 3 to 6 months. Then you make it 2 to 3 years as interval for those lesions less than 1 centimeter, or 1 to 2 years for lesion between 1 and 2 centimeter. But for the lesion more than 20 millimeter, the ASG recommend adding US for surveillance. So I will conclude with this algorithm. So if we have a subepithelial tumor, we do US actually in our hospital. If this lesion originating from the second or third layer, and it came to be hypoechoic, this is most likely lipoma, so you can leave it. If it's anechoic, we do a Doppler. If it's positive, this is vascular. If it's negative, this is cyst, and you can observe. If this lesion is hypoechoic, we consider is the patient symptomatic or asymptomatic. If the patient is symptomatic and the lesion less than 2 centimeters, you can go ahead with EMR, either using a conventional way or CAP or ligation assisted. If the lesion more than 2 centimeters, based on your expertise, you consider either ESD or surgical resection. If the patient is asymptomatic, you do a biopsy, either by using the US or by mucosal incision. If the diagnosis has been reached, you treat based on the histology. If there is no diagnosis definitive, so you can keep them in surveillance. If this lesion originating from the fourth layer, again, if the patient is symptomatic and the lesion between 2 to 4 centimeters, you can consider STAIR as initially, and ESD or EFTR, either exposed or non-exposed technique. But if the lesion is more than 4 centimeters, the recommendation is going for a surgical resection. And thank you.